OCD is a very serious disorder. People can become so depressed that they might even think about taking their lives. They might turn to substance use.
Hi, I'm Dr. Keshishian. Welcome to our podcast series, House Calls with Dr. K. During this podcast series, we're going to talk about a lot of different things, but specifically it's about medicine, the human side of medicine. We all have questions about our health, and who can you turn to? The doctors that you trust.
Hi everyone, welcome to House Calls with Dr. K. Today we're talking all about OCD, also known as Obsessive-compulsive disorder. Why? Because there is a theory out there that people with OCD have been having such a difficult time during the pandemic. We are lucky to have an OCD expert here today to help us understand this complex disorder. I'm joined by Dr. Barbara Van Oppen, who is a clinical professor of psychiatry and behavioral sciences at Keck School of Medicine. She is internationally known for her specialty in treating OCD and OCD-related disorders and has been doing this work for over 35 years. Hi, Dr. Van Oppen.
Hi, Dr. Keshishian, and I'm going to work on calling you Dr. K. I know you love it.
It's so nice to have you here today.
Thank you. I appreciate you inviting me, and I also want to thank you for the amazing work you're doing with all these podcasts. I think we're up to 31 of them, 2 seasons.
So many.
Helping a lot of people, so it's my pleasure to be here.
Thank you. Now, we are going to be talking about a pretty important topic today, and I'm sure there's a lot to cover. But one of the really important things is this image of what a person who has OCD, what they might look like. What do you think the common understanding of OCD is?
Well, that's a great question and something that's often misunderstood. And people with OCD feel really upset about how it's often portrayed in the media, right? So we have Monk, who is a goofy Tony Shalhoub, right? And then we have As Good as It Gets, that Jack Nicholson played, this germaphobe who took around plastic silverware everywhere. And then there's that movie, What About Bob, with that annoying patient who follows his therapist around. So those are comic characterizations. OCD is a very serious disorder. People can become so depressed that they might even think about taking their lives. They might turn to substance use. It's often misdiagnosed. I've seen people who have suffered from OCD for years that have been given diagnoses such as panic disorder, social anxiety, often even psychosis. So it's really important that it's assessed properly, and I'll get into that in just a little bit. But there is an array of presentations. First of all, people who are diagnosed with OCD have to meet the Diagnostic Statistic Manual for Psychiatry number 5 criteria. And that is the presence of either unwanted, intrusive thoughts, images, or impulses that provoke tremendous anxiety, so distressing that then somebody engages in various behaviors that can either be overt, such as hand washing, checking locks, making lists, repeating actions. We can go on about that in just a minute. And then those compulsions neutralize that distress in the moment. However, they just reinforce the disorder and reinforce the fears. And those symptoms need to take up at least an hour or more a day to meet the diagnostic criteria. For example, an average person, if all of you think about this past week, if you've done any appliance checking or lock checking because you wonder, what if I've left that on and I could start a fire, then that would be terrible. Let's say you've done that several times this week. You might even have a very low score on the severity scale. So OCD is very common in the general public, but it takes many faces.
And these many faces, right? Like there are different manifestations of OCD, like you mentioned. Can you talk to us and explain what these different manifestations might look like? You mentioned a few of them already.
Yeah, so there is something called the Yale-Brown Obsessive-compulsive checklist, which is a gold standard way of assessing OCD. And it's arranged by first obsessions in different categories and then compulsions. So as we just said, the common thought about OCD is it's somebody who's a germaphobe, maybe somebody who is also called anal, right? Very sort of rigid about the way things are done and kind of perfectionistic. But actually, when you do a deeper dive into OCD, it can be very idiosyncratic. And so people often report what's considered aggressive obsession. So these would be themes that one would worry about losing impulse control and hurt somebody, which is very different than somebody who is homicidal or suicidal, where there's that thought isn't experienced as alien, okay?
Right.
People with OCD get very confused, and there's something called thought-action fusion, and if they think about having some of these aggressive obsessions, they worry that that might mean that they could do that. So, I'm cutting vegetables, and a loved one is near me in the kitchen, and I might have a thought, oh, what if I just reached out and stabbed that person? Or what if I stabbed myself? Very common. Also worries about hitting pedestrians while driving, and then feeling terrible. People with these kinds of obsessions feel horrible about themselves because they think it means they're a bad person. Then we've got the garden variety, and I shouldn't really say garden variety, but there's a lot of different manifestations of contamination. So people can worry about contact with urine, feces, saliva, worry about getting an illness. Sometimes just the thought of having germs on one's hand or part of your body can cause distress, difficulty touching doorknobs and railings, things that are publicly used. And it's sort of just a not right kind of feeling, just a yucky feeling. Worries about pesticides, worries about environmental contaminants, radiation, toxic waste, asbestos. Some people are afraid of household cleaners because they see that skull and crossbones and think it could be poisonous. Sometimes people are worried about animals. Then there's a category that's sexual obsessions. So these are very similar to the aggressive obsessions, but they're worries about doing something inappropriately to somebody else that's of a sexual nature. So standing on a crowded elevator, which I know it's a thing of a past right now for most of us, but being in crowds and thinking, what if my hand just reached out and grabbed that person's genitals? Or what if I inappropriately touched a child or an animal? Okay. Then there are hoarding obsessions that can be part of OCD, although in DSM-5, hoarding actually stands alone. So it depends why the person's hoarding. So if they're hoarding things, papers, because they worry they might have written something that could be offensive to somebody or that is plagiarism, and then I save all these papers because I think I'm going to check it one day, that would be more akin to OCD. Then there are a bunch of other things, like a worry about not saying just the right thing, saying the wrong thing, a fear of losing things, having lucky or unlucky numbers, having colors that have a special significance. I mean, the list goes on and on, as you can see. And then there are, as I said, overt compulsions people engage in. Common ones are hand washing, checking, repeating actions, rereading. There used to be something that I wish never got into the literature that's called pure O. I've seen a lot of patients that come in and they say, I've got that pure O. They read about it somewhere long ago. I don't do any of those things. And what we've actually learned is that there really is no such thing as pure O. There is always some kind of compulsion that is meant to reduce the anxiety. Oftentimes they're covert, so they can be things like praying, making lists in one's head, repeating certain phrases to undo a bad thought. There's also reassurance seeking. I do not know one person with OCD who doesn't excessively seek reassurance, which takes us into the importance of involving family members and support people in the treatment. And then there's avoidance. A lot of people aren't aware that their symptoms may not score very high in this Y-box severity scale, and it could be because they're avoiding and seeking reassurance. So it's very important to assess for all of those sort of covert types of OCD.
Wow, that was really great explanation. I don't know if I could have done that. That was amazing.
Thank you. You know this is a subject close to my heart, so I'm going to have to restrain myself.
You are the expert. That's really helpful. Now, given all of these different manifestations, the symptoms of OCD can look very different. And I'm sure that the pandemic has affected people with OCD just as it has affected pretty much everybody. But how do you think the pandemic has affected, people who have OCD in different kinds of ways?
So that is such an interesting question because it's kind of split down the middle. So my experience with my patients who didn't have previous worries about illness, or I meant to leave that out too, kind of like people refer to those who worry excessively about illness as a hypochondriac. There is something called somatic OCD, where people think because they have a headache, they have a brain tumor, right? So people with the somatic OCD, as well as contamination fears that predated the pandemic, those folks are having a harder time because it's really difficult. I mean, like for many of us, right? Do I leave my mail outside for 3 days? Do I need to wash off my groceries? What's okay to touch, what's not okay to touch?
Money, gas station,
right.
What have you.
Exactly, on and on. And our knowledge has changed, right, in terms of droplet versus respiratory and all of that. So I think for the most part, the general public without OCD is pretty okay about keeping up with CDC guidelines, reading the information, and staying within a parameter, although we all know people who've gone a little overboard, right? Then there's the individuals with contamination and somatic obsessions in particular who don't really know where to draw the line, right? So they have worries that what if I have asymptomatic COVID, maybe excessively get COVID testing, again, avoid coming into contact with other people, not wanting to touch food or they might serve others, or excessive concerns for themselves. And then there's people with OCD that have all of those other symptoms that I just mentioned, and this isn't black and white, because they're people in general, if your anxiety is higher, your symptoms can be worse.
Right.
But I know a lot of people with the other symptoms of OCD who are actually doing very well. And in fact, on a whole, people with anxiety disorders, if it's not the contamination or the illness worries, if you think about it, because of stay-at-home orders, they're removed from a lot of triggers.
Yeah.
Right? So people with social anxiety, I'm fine, don't need any more therapy, or panic disorder, don't need to go out, just order everything to be delivered. So a lot of those triggers are removed. So there's a lot of people that are experiencing less of their anxiety symptoms than they did before. And then this is an interesting response, but one of my patients who has contamination, actually not just one, but many of them, but I'm thinking of one in particular, just last week was talking about how she feels a little bit of retribution or satisfaction that maybe now people in the general public know what it's like to worry so much about catching an illness.
Wow.
And having to hand wash.
Wow.
And go to extreme measures. She said, I kind of feel a little bit of gratification that maybe people will be more sympathetic to what it's like to have OCD. Because just like now, I mean, most of us, we don't turn it off from the minute we wake up till we go to bed. There's probably people that have COVID dreams. Right? And it's a 24/7 disorder.
That is so interesting. And some of us, you're right, have gone a little overboard. And, that might be what a person who has contamination, obsessional thoughts might feel like. It seems similar.
One of the very good ways to discern, and I talk to my patients with contamination about this, so people with OCD will wash their hands to, remember, as I said before, neutralize their anxiety. Right. So they're washing their hands because they think if they keep washing their hands, they'll get rid of the distress. Mm-hmm. People without OCD are washing their hands because they're following CDC guidelines.
Right.
It's not because I'm necessarily anxious in that moment. Right. I just want to do what makes sense to stay healthy and keep my loved ones healthy.
Yeah.
Right.
Yeah. No, that's very, very good. Thank you. So how do you think the treatment of those patients who have contamination fears has changed due to the pandemic?
Well, it's been a challenge. First of all, most of the sessions are via telehealth, right? And there's, I think most of us clinicians first felt like that was really going to hamper the therapy because the treatment is in-person exposure, which we can get to in a moment. But it's actually been very useful because we've been able to do the exposure in people's natural environments. So I'll have them on the video platform and we'll be doing the therapy together live in their home. So we actually been able to have more mileage from that. What's challenging is we've all had to pull back because the things I would do before the pandemic, and this may sound a little bit off for those of you who are unfamiliar with treatment of OCD, like sitting on the floor of a public bathroom having a snack. okay? Touching
Yeah.
the floor and then eating something, right? Touching the bottom of my shoes, then licking my hand, right? I know, it sounds silly, but these are the things that the therapist needs to engage in if they're going to model for their patient that these situations don't pose as much risk as the individual with OCD anticipates or expects it to. Now, I don't know, right? I don't think at the beginning of the pandemic I would do that. I don't think I would do that now necessarily, right?
Right.
So we've had to be more cautious. And in the OCD community, the going kind of rule of thumb is just following CDC guidelines. And there have been a lot of webinars and podcasts that have addressed this topic.
Thank you. Now, before we get to treatment, I think what we should talk about is, how do people, for lack of a better term, quote unquote, get OCD? When do you start seeing symptoms? What type of symptoms do you see?
Yeah, so good question. OCD is not like the flu. You don't catch it, okay? It is a biologically based disorder that has a genetic predisposition, just like everything in terms of eye color and hair color. I mean, we are a host of genes. And then certain environmental factors, such as trauma, even hormonal changes. A lot of times we'll see more severe presentations present around adolescence. There is pregnancy and postpartum related OCD and menopause. The youngest child that I've seen is age 4. Wow. And there is a group of very young kids that present with symptoms. And it's hard to tell because a lot of times young kids have rituals, right? They line up their toys, they line up their clothes, they don't want people to touch things of theirs. They might do a little hand washing or not like how their hands feel if sticky substances get on them. So it's a matter of the severity and the rigidity. Can the child be redirected, or do they really cling and almost look oppositional? A lot of time kids with OCD are misdiagnosed as having oppositional defiant disorder because they are so anxious that they could have tantrums if they can't complete their rituals or have their environment accommodated to.
Interesting. So let's say you are seeing some signs or symptoms that you're interested in exploring further. What should you do?
So I'll skip ahead, fast forward to some resources.
Yeah, why not?
One of the best resources is the International OCD Foundation. It's a nonprofit organization. They have a fabulous website, iocdf.org. And they, aside from all the other information that's on that site and many of the podcasts and webinars that I just referred to that are taped for people to view, they have something called Find a Provider tab. So you could go onto that tab and put in a city or a town and a radius of distance, and then you just plug that in and it will pull up providers that they're not vetted, so the OCD Foundation can't really go and inspect all of these and make sure that they are actually have expertise in OCD. But they're individuals who have identified themselves as being treaters of OCD. Some have completed the IOCDF Behavior Therapy Training Institute. So if it says BTTI, that's a good thing to look for because we know that that person has received specialty training. And it says if they take insurance, what kind of therapies they offer, what ages they offer, if they run groups, and so on. So it's a tremendous resource. So get to see. So let me just underscore one thing.
Yeah.
As you know, because we did an OCD group together in clinic, it makes a world of difference. So even if you have to pay out of pocket and try to get reimbursement from your insurance company, if you need to see an expert, because if you don't, you won't get the right treatment and you're wasting your time.
Thank you. Yes, we have treated many OCD patients together, and we've had a lot of fun. And when I say fun, I say it because it's such an interesting, different way than what you think of when you think of therapy. I think probably most people think of therapy in that you lie on a couch and you start talking about your feelings, which is not the treatment for OCD. So can you talk to us a little bit about how do you treat OCD?
Absolutely. I will preface by saying it will sound counterintuitive because when a person feels anxious, it's a natural tendency to avoid. We have a fight or flight response. So until somebody with OCD learns that what they're doing is actually making their disorder worse, it seems like the reasonable thing to do, right? Either avoid triggers or engage in compulsions that neutralize the anxiety.
Yeah.
It's very important to understand that the cornerstone of treatment for OCD falls under the broader umbrella of cognitive behavioral therapy. However, it's specifically called exposure and response prevention, or ERP, or you might see EXRP. And what that involves is purposely helping somebody to expose themselves to those triggers one by one until the anxiety naturally declines and naturally neutralizes without doing the compulsion. So for example,
all right,
when you go swimming, all right,
okay.
you go and jump in the ocean,
yeah.
right? And how does that water feel?
Likely cold.
Probably cold, but
yes.
You swim around for a while, and then what happens to the temperature?
It feels okay, not terrible.
Yeah, you kind of get used to it, right?
Yeah.
So did the temperature of the water change?
No, I don't think so.
Okay. Something happens physiologically. So we are evolutionarily equipped to experience something called habituation. And if you think about it, there's many situations like this. So you go to visit somebody who's living by an airport, and you cannot stand the noise of those planes, and you think, oh my God, how can they live here, right? Yeah. But if you stay for the weekend, by the end of the weekend, you're not hearing the planes either. So our nervous systems habituate or become used to what initially seems aversive. And that's the same thing with OCD. So if you can help people to just tolerate increments of distress, that increases their distress tolerance, and things that were once very anxiety-provoking start to drop down. Mm-hmm. Okay, and I'll get to the point in treatment where I have patients that say, like, oh my gosh, like, today went by, I realized I didn't even have an obsession. So you tend not to be noticing. We have thoughts, automatic thoughts, all day long, but it's the ones that cause us distress that we pay attention to. So once that distress starts to come down, they might have a random thought here or there, but there's not the need to do the compulsion.
Okay, so now for the listeners, we're going to simulate an ERP session. Is that okay?
Yeah,
all right,
let's do it.
So can you maybe walk us through some interesting sessions that you've had in the past and kind of what that would look like?
Sure thing.
All right.
Okay. Well, let me go with something kind of typical. So let's say there's something called magical thinking, right? Okay. And kids have this, right? Step on a crack, break your mother's back, right? As I'm do you have your phone?
I have my phone. I got my phone.
As we're putting our phone down on the table, I have this thought that my husband's going to get into a car accident. So I pick the phone up and put it down and pick it up and put it down until I'm able to feel just right that that's not going to happen. Okay. So I'm bringing in this other element of OCD that a lot of people experience, which is a kind of an incompleteness or not just right feeling. And sometimes it's coupled by an obsession, and sometimes it's just like standing up, sitting down, walking through a door back and forth, or opening a door until I feel just right. Okay. This is going to be accompanied by that thought. All right. So now the exposure to this would be that we're going to, as we put the phone down, we're going to say, because I'm not picking my phone back up, my husband will be in a car accident.
Will we say it out loud?
And we say it out loud. So, ready?
Okay,
I know
ready?
I know this. It's not, and again,
very uncomfortable.
We're not trying to teach the person to like these thoughts. It's to reduce the importance of them, because just because I've thought something doesn't mean it's going to happen.
Or I made a comment doesn't mean it's
and it's never anything good. It's like never like winning the lottery, right?
Can I put my phone down and win the lottery?
Ready?
Okay, ready. Okay.
Because I'm not picking up my phone, my husband will be in a car accident.
Oh, whoa.
How does it, on a 0 to 10, how uncomfortable is that 10 being the most?
Probably like a 4 or 5. It doesn't feel very good.
Yeah, I mean, most people don't like this, even people without OCD.
Yeah.
There was a study done where, and I wouldn't do this in session because now I'm distracting you, but there was a study done that administered aggressive obsession questionnaire to the general public, and over 90% of people endorsed having the same thoughts that people with OCD have.
Oh, so, for sure.
Right?
Oh, for sure.
So we all
We all have
can
that.
relate to this.
Yeah.
But what I would do, so Dr. K, if we were in session, we would repeat that several times. And let's say you're somebody your distress is at an 8. We keep going with that until it got to be about a 4. So we don't time the exposures because we might stop too soon, and then I'm reinforcing avoidance. So I wouldn't tell you to do it for a minute because maybe in a minute you're still at a 7. So we just keep repeating that. And then we would make a tape recording of ourselves saying the same thing and then listen to it, because you get even a little bit more distance and objectivity when people start hearing themselves say their obsessions. They're like, that doesn't really quite sound right.
Right.
Okay?
Yeah.
And we set up the therapy by creating lists that are called hierarchies of all the different triggers, and we rate them, just as I asked you to do on your subjective unit of distress scale. So the SUDS, we call it. Yeah. And it could be from a 0 to a 10. And then we'll start with the triggers, exposure to the triggers that are somewhere probably around 4 or 5 to give the person confidence about this approach.
I remember you and I have worked together treating patients with OCD. Yes. I remember doing the exposures with the patients. Some of them didn't sound super exciting for me to do either. And I'm sure you've had many yourself that you're like, I wouldn't want to do this either. How do you do you remember a specific example, or how do you get over that?
I do. There's something that pops up. So right after 9/11, there was a burst of fear about anthrax poisoning in the OCD community. Right?
Oh, yeah, that makes sense.
So I had patients that wouldn't open mail, that were getting notices from their utility companies that things were going to get shut off because they. So I had one patient that actually created like a mail room in her laundry room and suited up, like Chernobyl style, right, to bring in the mail, and had all the mail in there. Wouldn't let her husband touch it. She wouldn't touch it. We got to the point where she was in agreement to bring in some pieces of mail. And she brought them in about 5 different layers of Ziploc baggies, right?
Wow.
And I take a piece of mail because I'm doing the modeling, right? I want to show the person they're overestimating the risk. I open this letter and I take a big deep breath in, like, and she looked terrified. She's like, oh no, don't do that for me. You're going to get sick and you're going to die. And I breathed in and I was like, okay, now it's your turn. And we did this several times until she got comfortable with it. Well, into my next session, I started to have a sore throat.
Oh, no. Oh, no.
And I thought,
oh, no.
So, of course, I thought, like, did I just do something really harmful? But I didn't go home. I took a lozenge. I didn't go home. I didn't call the CDC. But, again, the thoughts come through, like, did I go too far here?
Oh, yeah. I mean, we get those thoughts every day.
Or when a patient cries and gets really upset and distressed, and I think, all right, now I really pushed it. But now I'm much better about being firm about exposure because I really know that this is the powerful ingredient. And I usually have people call me afterwards and say, thank you for, really being firm with me to do that. Is the best thing I did. I'm feeling so much better. So once you do enough of this work, you feel very confident about it. And I say that probably the rates are somewhere about 70-80% of people who undergo exposure and response prevention have at least a 35% improvement.
That's amazing. Yeah.
And it's interesting because people will say, well, why is there I know we haven't talked about medication, and I could keep you here for 2 hours, so I will make sure I don't go run on. But I do want to put out this information because it's important. A lot of people think that they can take medication and not do this work. Well, there are plenty of studies that show that looking at a placebo, so sugar pill, versus a medication called clomipramine, and combined clomipramine and ERP and just ERP alone. So people didn't have any improvement on the sugar pill. A little bit of improvement on the CMI. Sometimes these medications, SSRIs and NSRIs, can help with depression. And if somebody has depression and OCD and their depression gets better, then it'll help them to use the therapy for the OCD.
Sure. But
the outstanding finding of this, and it was published in 2005, Leibowitz and Foa were the primary principal investigators in the American Journal of Psychiatry. The medication combined group with ERP did not outperform the ERP group. So if somebody doesn't really need medication or doesn't want to take it and they're very motivated, you can do very well with the ERP, and plenty of imaging studies now have shown that the same brain changes take place with ERP as they do with meds. They hit the same targets in the brain. The good news, though, is if you do the ERP, the changes are durable. The improvement is durable. You just keep doing the exercises and you stay well. If you do just medication, come off the meds, within 12 weeks your symptoms are back.
So interesting. Now, one thing I think our listeners may or may not know is, how common is OCD?
So about 1 in 40 adults have OCD, about 1 in 100 kids. Now, this is that we know of. The prevalence is reported to be at least 6 million. It's about 2.5% of any population. This is a worldwide disorder. There can be slightly different cultural manifestations, but we know that this affects human beings worldwide. So very, very prevalent. OCD is as common as diabetes and asthma.
That's an amazing statistic. I doubt a lot of people know that. So there is help out there.
Tons of help.
And there are things that we can do, and contact the right people.
So iocdf.org is wonderful. We didn't get into, there's something called OCD related disorders that are a cluster of what we consider body-focused repetitive behaviors. And there is an organization that's wonderful for that too, with tons of resources, bfrb.org. Many, many books, many videos. I won't go into naming some because I don't want my colleague friends to get upset with me if I leave theirs out.
Yes.
So just go on the websites. You'll see all the resources. And if you need help, know you're not alone. There are also support groups. There are family support groups. There's a huge OCD community, and in Southern California we have an OCD affiliate that's called OCD SoCal. We also have a website for that, ocdsocal.org, and we are working on some virtual events because our obviously in-person walks and community awareness events and our annual conference are all on hold right now, but check us out. We're hoping to have a virtual conference sometime in 2021.
Dr. Van Oppen, I wonder, what got you so interested in OCD to begin with?
Good luck. Actually, good fortune. Seriously, I didn't mean good luck to you. I meant good fortune to me. One of my first jobs was at a private psychiatric hospital affiliated with Brown University, Butler Hospital. I was working in the admissions office, and the director of admissions was Dr. Stephen Rasmussen, to whom I owe my 35-plus year career. He needed somebody to do some research. He's one of the pioneers in OCD, hence the Yale-Brown Obsessive-compulsive checklist and scale. We were the Brown contributors. And at this time, OCD, this was 1985, OCD was thought to be a rare disorder with a poor prognosis. I didn't really know much about it. And so my task was to interview 60 individuals with OCD and do this 3-hour semi-structured interview. And the stories, popping jar after jar of spaghetti sauce because of not being sure that you heard the pop, and what if it's tainted and then you give it to your family and you poison them. Wow. Not being able to sit at right angles because of fear that there's somehow lasers coming out of your elbows and knees or fingers that could harm your loved ones. I mean, I know some of this sounds bizarre. It almost, sometimes people say, well, this sounds delusional. Although the difference is these people wanted their fears not to be true. They begged for reassurance. It wasn't like they were trying to convince me of their beliefs. So it was fascinating. And these individuals, as we talked, they were like, wow, this is the first time I'm really telling somebody about this. Because when you go over this checklist, you just do this very matter-of-factly. And people with OCD often don't easily disclose their fears because they're afraid that they'll get locked up, that people will think they're really going to hurt somebody or do something inappropriate sexually. Individuals feel like their thoughts are crazy and people would laugh. They feel shameful about these thoughts. Mm-hmm. And so, as I got to know these patients, and they were the kindest, wouldn't hurt a flea, only worried about other people, so caring, and it just seemed like an interesting disorder to treat. I also, because of my interest in family, was so curious what was going on in families, right? So if I think I have blood on money because I see red marks, and I ask my mother to wash my money, well, that's now impacting her, right? Or open doors for me, or not say certain things, right? So Dr. Rasmussen and I started a OCD and family support group, and it's still running.
You're kidding.
Once a month.
Oh my gosh, that's amazing.
And he's still at Butler Hospital. I know you're not going to hear this, Steve, but I'm going to give you a big shout out.
Oh, that's so great. Wow. Well, thank you so much for sharing the story, and thank you so much for all this great information. Now, before we end, I have a little game for you.
Okay. I knew you'd make this really fun.
Right? Okay. So we're not going to ask whether or not you've treated these people or anything like that. So no violations here. But the questions are, as you said, OCD is a very common disorder, and we live in Southern California. So what do we have? A lot of celebrities, and there are a lot of celebrities who have OCD as well. So I'm going to read you some list of names, and you tell me whether or not you think that they have OCD. Okay? Or if you know.
Okay.
All right. I'll start with an easy one. You ready?
As long as I don't have to name a Disney song.
That we'll get there.
Okay.
We'll get there. Okay. First name is Howie Mandel.
Yes.
Yes. Howard Stern.
Yes.
Yeah, you're right. Julia Roberts.
Well, if she's on this list, I hadn't heard about Julia.
Now, there are some yes and some no's.
No, I hadn't heard about Julia.
So we're going to go with a no?
I'm going to go with no.
You're right. She did, not that we know of. Not that it was
right,
out there.
that's exactly,
Not that we
okay.
know of. Okay. How about Justin Timberlake?
JT.
JT.
I could kind of see him as having OCD.
That,
I didn't.
It's all Google says so. Okay. David Beckham.
Yes.
Brad Pitt.
No.
Nope. Okay. Katy Perry.
Yes.
Wow, you're doing so good. Okay, Leonardo DiCaprio.
Well, he played the Aviator, which is, by the way, I think in terms of film, the best, the absolute penultimate portrayal. Very, very accurate. I think he does.
Yeah. Apparently he does something with doorways and per Google.
He did a good job. He did a really good job.
He did a good job. Robert Downey Jr.
No.
You are so good. You have gotten them all.
Some of these were pure guesses just based on
what you know.
Kind of what I know.
Well, thank you so much for joining us today. This was great. And, remember to everybody out there, there's always help whenever it's needed.
Absolutely. So please reach out. Lots of resources.
Thank you.
Thank you. Thank you for having me.
Thank you for tuning in today. Make sure to follow us on Instagram and Twitter, and to subscribe to the LAC+USC Medical Center YouTube channel, where you can find all of our previous episodes, in addition to the episodes located on anchor.fm/House with Dr. K. We also want to hear from you, so email us at lacuscpio@dhs.lacounty.gov. Thank you for tuning in, and see you next week.